Let's review some vocabulary. Flight of ideas. Flight of ideas is a symptom of mania, when an individual jumps from idea to idea quickly and erratically. Grandiosity is an unrealistic sense of superiority in which an individual may consider him or herself unique and better than others. Impulsivity, acting or tending to act suddenly and without carefully thinking about one's actions. So this might be overspending, promiscuity, driving too quickly. Labile, characterized by emotions that are easily aroused or freely expressed. These emotions might change quickly and spontaneously. It looks like emotional instability. Euphoria, a feeling or state of intense excitement and happiness. Delusions are a belief or impression that is firm in the individual's mind despite being contradicted by what is generally accepted as reality. So they would ignore rational arguments. Hallucinations, remember, is the apparent perception of something that is present even when it's not. And those can be auditory, visual, tactile, or olfactory. So someone may hear, see, feel, or even smell something that's not there. And delirium is an abrupt change in the brain that causes mental confusion and emotional disruption. It makes it difficult to think, remember, sleep, pay attention, and could be experienced during alcohol withdrawal or with dementia. Severe chronic illnesses, changes in metabolic balance, such as low sodium, medication, drug withdrawal, all of these things could cause delirium. Let's discuss the clinical manifestations of bipolar disorder in regards to manic characteristics. If you can see in the picture, there is the little Lego doll is the same person, but in 3 different colored outfits. And a person's personality can change significantly. So they look like the same person, but their behavior is very, very different when they have bipolar disorder. So manic characteristics may include labile mood with euphoria, agitation or irritability, restlessness, dislike of interference and intolerance of criticism, increase in talking or talking really rapidly, an increase in overall activity. So these individuals may be redecorating, shopping, may have a burst of creativity, or decide to start a new hobby like guitar. They may experience flight of ideas, so rapid, continuous speech with sudden and frequent topic change. They may experience grandiosity, which is a grandiose view of themselves or their abilities. So maybe they'll think they could be the president. Impulsivity, spending money, giving away money or possessions, promiscuous sex, driving too fast. They may have demanding or manipulative behavior, distractibility or decreased attention span, poor judgment, attention-seeking behavior, maybe like inappropriately dressing, wearing excessive makeup. And they'll see an impairment usually in social or occupational functioning and neglect their ADLs, including nutrition or hydration. These individuals will be experiencing a decreased need for sleep, and they may have delusions or hallucinations. In addition, they may be in denial of their illness. So the clinical manifestations of bipolar depression could include the same manifestations as unipolar depression. So flat or blunted or labile affect, tearfulness, crying, lack of energy, anhedonia, which remember is the loss of pleasure and lack of interest in activities, hobbies, or sexual activity. Physical reports and symptoms such as discomfort or pain, difficulty concentrating, focusing, problem solving, self-destructive behavior, including suicidal ideation, a decrease in personal hygiene, loss or increase in appetite and or sleep or disturbed sleep, and psychomotor retardation, which remember is that slow and sluggish feeling, or agitation, which is restlessness and inability to sit still. This is a visual representation of the mood range or spectrum that an individual may experience with bipolar disorder, all the way from severe depression up to severe mania. The mood disorder questionnaire is a standardized tool that places mood progression on a continuum for hypomania to acute mania and hyperactivity to delirium. So those individuals would be completely out of touch with reality. For patient-centered care, the care of the client is based on the phase of bipolar disorder that the client is experiencing. So in an acute manic episode, we want to focus on safety and maintaining physical health. Within an acute care mental health facility, we want to have a therapeutic milieu or environment, so a safe environment in the acute phase. We want to regularly assess the client for suicidal thoughts, intentions, and escalating behaviors. We want to decrease stimulation without isolating the client if possible. So loud noise, loud music, other clients or patients could all escalate the client's behavior. We want to follow agency protocols when it comes to seclusion and restraint. Remember, we want to keep them in the least restrictive environment. So we do not restrain or put anybody in seclusion unless they are a threat to themselves or others. If possible, we want to get them to sit down and rest and be still, but also provide outlets for their activity. So often these clients are interested in journaling, and when they journal, they may write all over the page. It won't be in order. They might like art activities. We want to protect our clients from poor judgment and impulsive behaviors. So we don't want them to give away all their money, buy $10,000 worth of nail polish, have a lot of sexual indiscretions. We want to make sure they're getting their self-care needs met. So sleep, fluid intake, and nutrition are our main focuses, as well as we might want to help them with their clothing choice and provide foods that they can eat quickly. You'll read in nursing books, and you'll see this on tests, to give these individual things like cheese sticks so that they can run around and eat. In my experience, they can sit down and eat. However, they eat very, very quickly. So we want to make sure that there aren't foods that are choking hazards. When we communicate, we want to use a calm, matter-of-fact voice with a concise explanation, and we want to be consistent with limit setting and our expectations. Avoid power struggles, and we want to listen. Reinforce their good behaviors. These patients are going to need medications such as mood stabilizers, including lithium or anticonvulsants. Short-term benzodiazepine use can be helpful. Your textbook says that these individuals could use antidepressants, such as Prozac, to manage a major depressive episode. However, that could make them manic. Your book also leaves out that antipsychotics can be used as really the only medication for many of these patients to control bipolar disorder. So we have to teach to what the NCLEX says, but just keep this in mind in practice. Therapeutic procedures such as ECT, which is electroconvulsive therapy, could be used for extreme cases. And in client education, we want to have case management if possible, follow up with the client after they're discharged, psychotherapy. We want to teach on the need for long-term medication. Medication compliance is an issue. People start to feel better and then they stop taking their medications and it starts all over again. So how do we manage relapses in the future? What are the ways to manage crises? What are precipitating factors? So if a person sees sudden sleep disturbance or they're using alcohol or other drugs, these are things that we could avoid or control with good communication and good teamwork between the patient and the healthcare provider. So again, medication administration and adherence is a really important point for client education. Complications. So complications could be physical exhaustion and possible death. So a client in a total manic state would not stop moving and may not eat or drink. Again, this is what the book says, and this can become a medical emergency. More likely, their risky behaviors could lead to this possible death. So driving too fast, climbing a water tower, thinking they won't fall off the bridge they're walking across, really risky behaviors because they think they're invincible. So this is where the nurses come in. We want to prevent self-harm, and often that could be within acute manic phases, hospitalization for the short term. We want to decrease this manic activity, make sure they're getting enough to eat and drink, try to keep them on a sleep schedule, but really just help them with basic self-care until the medication works appropriately.